Topic of the lecture is bacterial pneumonia. But before we get on to bacterial pneumonia, we have to know what pneumonia is. Pneumonia is an infection of lung or lungs. It can contain both lungs, and it can be caused by any organism. Like it can be caused by bacteria, it can be caused by a virus, it can be caused by a fungi. But due to its prevalence, bacteria contains the highest rank. Bacteria is the most causative among all of them. So what a bacteria does, the bacteria gets inside that respiratory system and it causes the inflammation of air sacs called alveoli. With the inflammation, fluid or pus is accumulated in the air sacs or alveoli, and it's difficult for a person to breathe. When a person is not able to breathe, he's going to get pneumonia. He's going to get that labored breathing, which is associated with pneumonia. So there are like 4 types of it. First, we have to know in bacterial pneumonia whether it's typical or atypical. What's typical and what's atypical? Typical pneumonias are those pneumonias in which air sacs are involved. Those alveoli are involved rather than the involvement of interstitium. So when alveoli are involved, that fluid, that pus will be accumulated in the alveoli, and when we go for CXR, chest PA view, we'll see consolidation. That consolidation may contain only a patch, that consolidation may contain a whole lobe. But that will happen in a typical pneumonia, and it will have all the typical symptoms of fever. Patient will have fever, patient will be coughing sputum, and everything else will be going on. But what happens in atypical pneumonia? Atypical pneumonia is caused by viruses and some bacteria. In that kind of pneumonia, it doesn't affect the air sac, it affects the interstitium between them. It affects the parenchymal tissues. It gets inside, attaches itself to the respiratory membrane, and then starts damaging that. But as it's running inside the interstitium, as it's running inside the membranes of alveoli, we cannot see it on chest X-ray. And as it's inside those membranes, as it's inside those alveolar spaces, it's not in alveolar spaces, as it's inside those intraalveolar membranes, we cannot see any of it on the chest X-ray. So what will we do? We'll go for the symptoms. Patient won't have any kind of symptoms. Patient won't have that severity of symptoms because patient does not have that kind of infection to produce sputum. So patient will have dry cough. Patient will have mild fever, not severe fever, not even moderate fever. So that's why the behavior of that kind of pneumonia is so atypical that we call it atypical pneumonia. But bacterial pneumonia is always going to be typical. It's always going to be with high fever. It's always going to be with a sputum. It's always going to be with a consolidation. And we will know what kind of bacterial pneumonias cause this. And before getting on to that, we have to know there are 2 types of it. Either they're community acquired, either they're not. And in this lecture, we're going to talk about all of them. So let's start. Let's start with community acquired bacterial pneumonias. This is a person. What bacteria do you think are most probably going to get inside the respiratory system and cause pneumonia? These are organisms which are highly probable for causing pneumonia inside a person. Mycobacterium tuberculosis, streptococcus pneumonia, legionella pneumonia, and mycoplasma pneumonia. And among these four are the most probable. But among these 4, streptococcus pneumonias are the highest ones. They produce at least 40 to 45% of all the pneumonias inside those community acquired pneumonias, inside this whole chapter of pneumonia. So we have to know streptococcus pneumonia. We have to understand streptococcus pneumonia in case to understand the whole pathophysiology and to treat the cause afterwards. Let's see a chart here which shows that this whole part of a circle is contaminated by streptococcus pneumonia, meaning it's at least 40% of all the pneumonias are caused by streptococcus pneumonias. Further, we have H. influenza. H. influenza will be the second most common cause of causing pneumonias. Let me tell you, H. influenza is that bacteria which is very opportunistic. It causes mostly secondary pneumonias. For example, a patient has a sore throat and presents to you that I have a sore throat and stuff, but that patient does not have pneumonia yet. But if that patient is subjected to, if that patient is exposed to H influenza, that patient is going to get pneumonia. It causes secondary pneumonia, so it's highly prevalent. Afterward, we have M pneumonias, mycoplasma pneumonias. It's very high yield. It's very important to know all the pathology regarding mycoplasma pneumonia. Afterwards, we have C pneumonia and legionella pneumonia and then anaerobes. These all contribute very small part in causing the disease. But three big chunks in causing pneumonia are streptococcus pneumonia, H influenza, and mycoplasma pneumonia. So we're going to talk about all of them in detail. First of all, let me tell you there are two types of community-acquired bacterial pneumonias. Either they can be lobar, either they can be bronchopneumonia. So when will it be lobar, when will it be bronchopneumonia? I told you a bacteria gets in, it goes to the alveolar level, starts the inflammation process, starts the whole exudate starts appearing in all the inflammatory mediators are coming in. If that bacteria has gone to the alveolar level and started the damaging part in the alveoli and started the damage in the alveoli, it's going to be lobar pneumonia because that alveoli will be communicating with the next alveoli through Kohn spaces, Kohn. Kohn spaces, they communicate with each other. So this will spread through those spaces and this will contain the whole lobe. That's why it's called lobar pneumonia. It compromises the whole lobe of the lung. On the other hand, what is bronchopneumonia? Bronchopneumonia is a condition in which the bacteria came in the same way, but it did not go to the alveolar level. It stopped at bronchi level, at bronchiole level, and it started the damage from there. It started the damage in that area, and afterwards it affected the adjacent alveoli. So its primary target wasn't alveoli, its primary target was bronchi or bronchiole. So that's why it's called bronchopneumonia, because the alveolar damage is secondary to what was intended in that case. Let's talk about the most probable organism found in the pneumonia patient, pneumococcal pneumonia. What do you think will be the pathological slide be showing? As you can see, a lot of cells. Hypercellularity is seen in these cells. Hypercellularity is seen in these cells because all of the cells are here now. All of the fibrosin factors, all of the inflammatory mediators, transudates, exudates, neutrophils, eosinophil, all of these cells are here. So hypercellularity will be seen in case of pneumococcal pneumonia. As you can see, this is a phase of red hepatization. I'm going to tell you what red hepatization is in the further slides. But look at this. Patient is going through a lot. This hyper kind of cellularity. Cells are being torn apart. Cells are being degraded. Cells are being phagocytosed in the whole process. So we have to know that what are the risk factors of pneumococcal pneumonia. Just close your eyes and just imagine that what kind of person will get pneumococcal pneumonia. In order to know that what kind of person will get pneumococcal pneumonia, we have to know how pneumococcal pneumonia is transmitted from one person to another person. Most probably, there are colonies inside your GI system of pneumococcal pneumonia. If a person aspirates, it goes down into the respiratory system and causes that. So aspiration is a basic cause. So how will we get it from other person? We'll get it from other person through talk, through contact. If we have had a contact with that person, we're going to get that. So what are going to be the risk factors inside this? First of all, because it's a community-acquired pneumonia, wherever there will be a huge amount of community, a large number of community, you're going to get it. If even 1 or 2 persons have it. If you have had contact with them, you're going to get it. So first risk factor is going to be community. Community which has been exposed to this kind of problem. Further, we have to see what other risk factors we have is if the patient is 65 years old or older than that even. What happens in that? The immune system goes down. The immune system is not compatible to fight this kind of infection. So what happens? They develop pneumococcal pneumonia. Cigarette smoking. Why cigarette smoking is affecting in this whole process? Because when a person is smoking cigarettes, what's happening inside the body? Mucus production has been increased. There's a lot of mucus, but those mucosity response has been kind of diminished. So it's accumulating. That junk is accumulating inside your lung. And if that junk is accumulating inside your lung, it's very hard to take it out, and those bacteria will colonize there and cause pneumococcal pneumonia. Afterwards, we have irritants. Some people have irritants like some kind of allergies or something like that, and if they are exposed to them, secondarily, pneumococcal pneumonia can happen. Immunocompromised patients, those patients who are immunocompromised already. For example, if a patient is suffering from HIV, that patient, if even slightly exposed to pneumococcal pneumonia, will get it because its immune system is not enough to withhold that infection, to withhold that organism. Chronic illnesses. In chronic illnesses, you can say if a patient is suffering from emphysema, if a patient is suffering from chronic bronchitis, these patients are going to get it. Afterwards, we have heart disease. In some patients, heart disease is the predisposing factor for getting pneumococcal pneumonia. There's one very important risk factor which has not been mentioned here, and that is aspleen. If a spleen has been removed or a spleen function has been compromised, that person is going to get it. Why? Because all of the blood goes to the spleen for removal of the waste products and stuff. What does spleen do? Spleen picks up all the capsular structures and destroy them. But if there is no spleen, or even if the spleen is present and the function is not optimum, those capsular structures won't be picked up. So what will they do? They'll cause an infection. So asplenia is the major risk factor in the pneumococcal pneumonia. Now let's talk about the pathogenesis. What is going to happen inside that alveoli? What is happening inside that cell that is causing all of this trouble? Let's see. As you can see, this is pneumococcus. It's coming in. It's going to get inhaled inside the body, and then it reaches that level, and we have capillaries around. We have type 1 pneumocytes around. We have type 2 pneumocytes around. So what will they cause? They'll cause edema immediately. They are foreign substances which are going to be engulfed, or macrophages will come in or something like that, and they'll cause edema. And what will happen? The first result will be edema will happen, because a foreign product, it has caused the edema production inside that cell. What will happen when a person is getting edema in an alveoli? That alveoli won't be able to function. And that's how it will attract the attention of all the immune complexes, all the structures inside our body which are supposed to protect us from any foreign substance. So what will happen is a lot of red blood cells, a lot of neutrophils, a lot of eosinophils, a lot of macrophages and transudates, they will all be attracted towards that cell to fight that combatant. As you can see, you have RBCs here, you have congested capillaries. Why are there congested capillaries? Because there's infection going on. So what will happen? This place will go for vasodilation and will keep vasodilating, and these capillaries will be congested. And then we have pigments containing bacteria. And this phase is called red hepatization. Because of edema, because of all these processes that are going inside that cell, the consistency of that cell, and as it's not the only cell that's being affected, there are a lot of cells that are being affected through that window of Kohn. It has communicated with other cells. So what's happening is that the consistency of the liver is very hard. So due to edema and due to all these things, that spongy character of lung is lost in that area. That spongy nature has been lost, and this nature has been converted to a hepatized nature. Now the consistency is of a liver in that area. And why it's called red hepatization? Because when you look at it, when you look at the cross section of it, you will see red kind of it, red color inside of it. Why is that? Because of RBCs that are present right here. Hope you got the point that why it's called red hepatization. What will happen afterwards? We all know red blood cells can't stay there forever. They have to be lysed, they have to be phagocytosed, they have to disappear one time or another. So that's what happened in here. You can see there's fibrin, but the red blood cells are gone. They have been engulfed, they have been lysed, they have been removed. So hepatization is still there, consistency is still there. But what's gone? That red color that we were talking about. That red color due to which it was being called red hepatization. So what will happen now? All we will have are macrophages who have engulfed that. Fibrin material is there. And that's why it's called gray hepatization. Because consistency is the same, but red cells are gone. All the other cells are there. And in this phase, patient starts producing yellow sputum. Yellow sputum comes out of it because there's a lot of infection going on. Sputum comes out. It's mostly yellow in color. And you know there's a huge amount of infection going inside your body. After gray hepatization, in normal person, I'm talking about the normal person. I'm not talking about an immunocompromised patient. I'm not talking about a chronic patient of some disease. I'm not talking about an anemic patient. I'm not talking about an elderly patient. I'm talking about a healthy individual with normal immune system working. What will happen that after gray hepatization, all of these macrophages which are present here will engulf all the foreign material and end this infection. All the debris will either be reabsorbed or this debris will go through mucociliary escalator and be swallowed. So all of this will be gone in a normal person. It takes around 7 to 15 days. It varies in every person's case that how much days this infection goes on. But in a normal person, in a healthy person who has a good immune system inside his body, is going to get resolution. Infection will be gone. Patient will be better now. But what happens if the person doesn't get resolution? What will happen? Those are called complications. We'll talk about the complications if the resolution doesn't happen. Before that, let me show you that on a histological slide, what will happen in pneumococcal pneumonia. As you can see, there's a bunch of red cells present. That's why this is most probably a red hepatization phase slide. You can see red cells and there's a macrophages present. They're like transudate exudate being formed, and they're like fibrogen factors present. And that's all that's happening here. As you can see, look at it. The interstitiums and these spaces between them, these membranes between them are not affected at all. They're going to be affected in atypical kind of pneumonia. What's being affected here? Air sacs, the alveoli. They're their primary target. So they're being affected here. There's multi-hypercellularity here. A lot is going on. So you can just look at it and see that it's a pneumococcal pneumonia. So I just told you that if a person doesn't get resolution, what will happen to that person? There are going to be complications. For example, resolution didn't happen. What happened? Fibrosis. In that area, fibrosis happened and it led to the formation of some empyema or something like that. When empyema will occur? When it has involved the pleura. When pleural involvement is there, that patient will also get empyema. And after that, there's a bigger chance of forming an abscess in the lung. If that area is fibrosed, there's bigger and bigger chances of formation of any abscess in the lung. And then there's a huge chance that those microorganisms can disseminate and go inside the system. This organism can go inside the system through your bloodstream and get to the brain, cause meningitis, get to the other systems and cause their complications. So there are a lot of complications. We're going to talk about the following. First of all, you can see pleuritis in this patient. As the patient is already going through a lot and it's not going to get resolved, pleuritis will happen. What else can happen? Lung abscess can happen. I just told you lung abscess is a higher possibility of being formed inside this case. Then we have bacteremia. What is bacteremia? Those bacteria have crossed that barrier and get inside your blood. That's called bacteremia. Bacteria are being colonized inside your blood, and they are going to affect one system or another. They can even cause sepsis inside you. Afterwards, we can have pleural effusion. If pleura is involved, pleural effusion is going to happen inside this person. What else can happen? Empyema can happen. I just told you that empyema can happen if pleura is involved. What else can happen? Pulmonary fibrosis. If resolution is not happening and that inflammation and that infection is going on and on and on and on, what will I do? To wall off that phenomena, fibrotic agents will come in and fibrosis will be caused. So pulmonary fibrosis is a major complication inside of pneumococcal pneumonia. So what will be the clinical feature of that patient who is being subjected to pneumococcal pneumonia? We already talked about fever and chills because there's huge amount of infection going inside your body, huge amount of infection happening inside your alveoli. It may be lobar pneumonia or it may be bronchogenic, but it's affecting a whole lobe or at least patches of your lung. So there will be fevers, there will be chills, then there will be dyspnea. Why dyspnea is happening? Because alveoli are not taking part in gases exchange as better as they were before. So patient is going to get dyspnea. Patient is going to get rusty sputum. Why rusty sputum? Because a huge amount of infection is going on inside this phase of red hepatization. Sputum is being formed and there's a lot of junk, and that rusty sputum will be formed in that phase. Patient will have loss of consciousness. Why patient will have loss of consciousness? Either because of increased temperature inside your body due to fever, either it has affected the other system, either it has caused septicemia, or it has just caused a drop in your blood pressure because it's not oxygenating the blood enough. And then it causes debility in which a person is not able to perform that kind of function which he is used to or she is used to perform in the daily tasks. On morphological slide, you can see this is how pneumococcal pneumonia will present to you. You can see this is how pneumococcal pneumonia will present to you. It's in red hepatization phase yet. One thing you must know that not all the pneumonias are going to get through all the phases. With the improvements in medication, with the improvements in antibiotics, it has been improved a lot that maybe it's an even red hepatization phase and you have treated it well and it's gone. So it's not necessary that it goes through all the phases. Now we're going to talk about streptococcus pneumonia. We just told you that major reason for pneumonia are the 3 bacteria, and this is one of them, streptococcus pneumonia. What streptococcus pneumonia does? On a morphological slide, you can see streptococcus pneumonia like this. See this bunch of vesicles formed, this bunch, always 2 in number that present in a tuft. On a radiological slide, you can see streptococcus pneumonia in the apical area, and it contains almost a whole lobe. But with streptococcus pneumonia, there's an increased chance of formation of an abscess. Abscess can be formed in this case. So you have to look for an abscess inside a chest X-ray of a patient who's suffering from streptococcus pneumonia. Afterwards, we have to know what the pathogenesis of streptococcus pneumonia is. So before the pathogenesis of streptococcus pneumonia, let me tell you what's the colonization part of streptococcus pneumonia. What's the favorite place inside your body for streptococcus pneumonia? It's upper respiratory tract. They colonize there. See, at nasal epithelium, mucus is being formed. Streptococcus pneumonia colonize very rapidly. So what will happen? It will get transmitted through your nasal cavity. You will have runny nose throughout the day, and when that runny nose is happening, you will try that to take it back in. So what will happen? Invasion will happen. If you aspire, it will cause pneumonia. If bacteremia happens, it will cause meningitis. And if it's only local spread, it will cause otitis media. There are bacteria present inside your nose, inside your nasal cavity. They're being colonized. There's runny nose. You try to take it back, or somehow that bacteria goes on itself, and you aspire that bacteria inside your respiratory tract. It gets inside your respiratory tract somehow. It's going to cause pneumonia. But what if it gets to your bloodstream? It's going to cause meningitis. It will cause that barrier. And if it doesn't go anywhere, we all know the nose is connected to the ear, and specifically middle ear, so it's going to cause otitis media. So what are the risk factors of streptococcus pneumonia? What patients are predisposed for getting streptococcus pneumonia? First of all, people who drink. Why? Because they don't know what they're doing. This gives bacteria most perfect environment it can get for colonization. People who drink get this, people who smoke get this, because their respiratory system is already compromised somehow. And afterwards, you can see if a patient has low HP or something like that, and children specifically get that. And if patient is already suffering from some other chronic disease. So these are the risk factors for streptococcus pneumonia. Now we're going to talk about Haemophilus influenza and how it causes the pneumonia. As you can see, Haemophilus influenza, yes, it does affect the alveoli, but it does also affect the interstitium. Look at the slide. These are the cells which are going to be found inside that affected organism, affected cell. And what will you find on Haemophilus influenza's radiology? You can see it's diffused. It's not affecting any specific lobe. It's majorly affecting those interstitiums. But in some areas, it's also affecting some alveoli. So it has a very patchy appearance. It has a very radiant kind of appearance on the chest X-ray, that it's affecting every place there is, as you can see. What are the risk factors for H influenza? We know if a patient is suffering from cystic fibrosis, it's going to get H influenza. From the first slide I told you, H influenza is the most opportunistic bacterial organism ever. Many of the cases, it won't do anything by itself. It will just wait for a person to get some disease, to get its immune system down, and the moment its immune system are down, H influenza is going to come in and cause a secondary infection. If it's a viral infection, if it's a viral pneumonia doesn't do much. It won't have any symptoms because it's affecting the interstitium, so it won't be even causing the sputum. There will be only dry cough present, itchiness present, but nothing more than that. No fever whatsoever, just mild amount of fever, mild kind of fever. But when that infection is already happening, H influenza will come in. H influenza will barge in and cause bacterial pneumonia on top of that viral pneumonia. So if a patient comes to you and says that I was like having runny nose and I was having itching in my throat and mild cough, and now suddenly I've developed all of this, that I have high temperature, I have yellow colored sputum, I don't know what happened inside 2 days. So you have to know that it was actually that viral pneumonia which has been complicated by bacterial pneumonia now, which has been superimposed by H influenza now, and it's going to cause all of this. So if a patient is already suffering from cystic fibrosis, that person's immune system is already down. Those lungs are already down because of increased mucus production. What happens in cystic fibrosis? Increased mucus is produced. Your lungs are not even mature enough. So those patients are at higher risk factor for H influenza to come in, to barge in and cause the infection. What else? Bronchiectasis. Any other lung pathology that's happening inside the lung, H influenza is going to take the benefit out of it because your system is already being affected. Chronic bronchitis. Next is what chronic bronchitis? Because it's a chronic condition, it has your immune system down on its knees. So one way or another, it will cause pneumonia due to H influenza. Let's talk about the pathogenesis of H influenza. First of all, there will be transmission and it will adhere to the mucous surface. It will replicate very rapidly and it will cause viral upper respiratory tract infection with it. Let's talk about Moraxilla catarrhalis. On radiological slide, you can see these angles even are compromised and you can see all of the lungs are affected somehow. There's patchy appearance and interstitium is involved. On a pathological slide, you can see a bunch of cells present together, and this will be the slide on pathological microscope to see if Moraxilla catarrhalis is present. As you can see, these structures are very visible, very viable. Staphylococcus aureus, the most debatable organism to cause a very complicated situation. You have all heard the name of MRSA, methicillin-resistant Staphylococcus aureus, or methicillin-sensitive Staphylococcus aureus. In this condition of pneumonia, we have to just pray it's methicillin-sensitive. So what's happened inside the pathogenesis of a Staph aureus organism? When a Staph aureus organism gets in, what happens? As you can see, it's a Staph aureus. It has these structures coming out of it, these kind of ISDA, CLFP, and WTA receptors present, and they have to interact with SERCA1 on the squamous epithelial cells. And already there's invocarin, cytokeratin, and loricrin are already present. So they are going to interact with them in order to damage those cells. So what's going to happen in nasal and lung and mammary cells? These cells are mostly prone to this kind of infection, mostly prone to Staphylococcus aureus infection. So in this topic, we're talking about lungs. So in this, what happens? It's going to make contact with it. As we were talking about, CLFP is going to convert to CLFA. It's going to interact with annexin A2, and those FNBPs are going to interact with fibronectin integrins, and it's going to cause that effect on that alpha 5 beta 1 receptor site. So this effectively produces, which is going to cause the further damage inside that cell. So what will be happening inside that Staphylococcus aureus morphology? You can see a big hole inside of it. It causes the necrosis. It causes even phagocytosis in that patient. It immediately destroys the whole cells present inside of it. As you can see, that bunch of cells present here right away, it's present in always in a colony of something. Now let's talk about what will happen to Staphylococcus aureus radiology. What will we see on radiology? Look at this. A whole area which has been marked, which has been surrounded. This kind of infection will be happening. Angles will be lost. There will be interstitial damage. So we can see that too in patchy appearances. But you can see this is the major effect of Staphylococcus aureus. This is what you will see in the mostly in the apical areas of the lung. Now we're going to talk about Klebsiella pneumonia. The name of Klebsiella tells you that it's going to give you claps. It's going to give you claps inside your nails. So this happens in mostly those patients which are very poor, or they have been subjected to malnourishment. They are going to get Klebsiella pneumonia. They are at higher risk factor for getting Klebsiella pneumonia infection, for getting the disease. Klebsiella pneumonia cells are mostly capsulated, and when you look at their morphology, you can see these cells in dispersive nature. You can see this is a capsule and cell present here. On radiological slide, you can see how it affects the lung. It's not affecting any lobe, but it's affecting in a different kind of manner. Let's talk about P. aeruginosa. What will happen inside the pathogenesis? How P. aeruginosa is going to affect it? We all know that the pathology, the basic pathology, is going to be the same. They're going to get there. They're going to affect the alveoli or interstitium or their spaces. But what happens in different organisms is different for them. For example, streptococcus pneumonia did have a very different kind of MOA from pneumococcus pneumonia. And just like that, P. aeruginosa and P. aeruginosa, increased number of P. aeruginosa comes inside your lung. Recognition of P. aeruginosa by host cells. So what will they do? They will activate the whole immune system. And that immune system and that whole process will get to the release of pro-inflammatory cytokine. Inflammatory mediators will be released. And this will start with recruitment of neutrophils to get there, because the bacterial infection, all of the neutrophils will be there, and release of elastase and other functions by neutrophils. Neutrophil release elastase to destroy it. Many other functions elastase has. So all of this will be happening. Aeruginosa came in, body cells recognized it, that oh my god, there's a foreign substance there. It alerts the whole system, there is a foreign substance here. Neutrophils will be recruited, that it's time to remove an infection. All of the other helper cells will be there. So what will happen? That release of elastase and other factors of neutrophils will lead to this. You can see congestion. Congestion is happening inside of it. And degradation of antimicrobial factors will happen. So reduction in mucociliary clearance because of degradation of antimicrobial factors and because of this elastase and because of this infection happening in those areas that mucus which are produced by the cells and then moved by the cilia are going to be affected. Mucociliary response will be gone. If mucociliary escalator is gone, what will happen? All of that junk is going to get accumulated inside of your cell. All of that junk is going to get accumulated inside of your body. So how to remove them? You cannot remove it. There's no other way. They're like only possible way is for absorption. And in this amount of exudates and transudates being formed, we cannot even do that. So the only option, only viable option we have is to remove it, immediately. And that is only possible if mucociliary response is happening. But in this pathogenesis, in which it came in and got recognized and pro-inflammatory cytokines were released and activation and recruitment of neutrophils happened and the elastase was removed, in this whole pathway, mucociliary response is gone. Mucociliary escalator is not working at all. So this will start accumulating. And when the junk starts accumulating, it gives the organism a perfect place to colonize and a perfect place to cause the infection. Because even the debris is not being removed. So increased number of P. aeruginosa is going to get to reduction in mucociliary clearance. On a morphological slide, this is how P. aeruginosa will be seen. You can see these spaces, they are being affected, and look at that. Due to that elastase being released, this is what happened. This red color that is here, that was due to that release, blood and stuff. And look at these cells, they are being, they were under the effect of P. aeruginosa. And when you look at histological slide, this is how it will be shown. It's always in tuft of cells, 2, 3, 4 cells present together. What will happen to the radiological finding of P. aeruginosa? It will always take the upper lobe. Not always, but most probably it's going to get to the upper lobe. And it's going to affect, it can affect a whole lobe. It can affect just in a patchy way. But in this slide, as you can see, there's a whole lobe affected. This is a P. aeruginosa pneumonia, pneumonia caused by P. aeruginosa. Now let's talk about L. pneumophilia. What will happen inside of it? You can see same pathology happening in every case, that it's going to affect either a lobe, either the bronchopneumonia. These are the two possibilities. You can see a whole lobe is affected, but even more than a lobe is affected. And you can now clearly see the interstitium. You can see the even interstitium. So it means there's infection present in that too. On a pathological slide, this is how it will be shown. There's hypercellularity, and in that hypercellularity, you can see these cells present right here. These are the landmarks of L. pneumophilia to be recognized and to be found in this kind of slide. Finally, we have mycoplasma pneumonia. It's a large contributor in pneumonia. We saw that slide in which, first of all, streptococcus pneumonia was there, which was the largest contributor. Then we had itch influenza, which was the second largest contributor. And then we had mycoplasma pneumonia. It's also a great contributor towards the pathology of pneumonia. So what will be seen on the morphological slide of mycoplasma pneumonia? This is what will be seen. A lot of pus, a lot of fibrosis. Look at this. A lot of pus has been formed. A lot of degradation has been happening. And you can see the early appearance here. You can see this happening, early appearance, these red streaks, and pus will be here. So this early appearance is landmark for mycoplasma pneumonia. On a radiological slide, you can see that it's going to affect most probably the apical area. But in this disease, in this pathology, it's not only going to affect the lobe or bronchopneumonia like involvement. No, it's going to affect the interstitium very badly. So you can see, you can actually easily see the interstitium. You can actually easily see those lines going in and out. So that's what mycoplasma pneumonia does to that person, to that radiological finding. So let's summarize what we have studied in this lecture. We started with pneumonia, that it's an infection. It can affect one lung or the both lungs, and it can be affected by bacteria, virus, or fungi. But in this lecture, we talked about bacteria. But when it came to bacteria, we had to know that whether it's going to be community acquired or not, whether it's going to be typical or not. Most of this lecture's part was about typical bacteria and typical pneumonia. What's typical pneumonia? We already talked about. There's going to get that consolidation happen. Consolidation will happen because it's going to affect the air sacs. It's not going to affect the interstitium just like atypical cells. So we knew that typical pneumonia is the basic reason for all of these pathologies that we studied right now. We studied that what organisms are the basic cause of community-acquired pneumonia. There were 3 basic organisms. You have to remember them on your fingertips: streptococcus pneumonia, H. influenza, and mycoplasma pneumonia. And there were other organisms like we studied, like P. aeruginosa and stuff, but those are not high yield. You have to remember these 3 because they make like 80% of the whole possibility of pneumonia. Then we studied about their pathophysiology, how they're going to affect, how the consolidation will happen, what is gray hepatization, what is red hepatization. Is actually, there's only one difference between them. The red blood cells are there in red hepatization, but in gray hepatization, they are gone. Then we studied the resolution happen. If it doesn't happen, it leads to complications, and those complications are very severe in some cases. And then we studied every single organism which are there to cause that pneumonia. We just saw how their morphological slide will be seen, how we see them on the microscope, how we see their chest x-ray. So I hope you will be able to recognize any kind of x-ray now which is related to community-acquired pneumonia and specifically bacterial pneumonia. I'll see you in the next lecture. Thank you so much.